The commission meeting will now come to order. Commissioners, in your packets are copies of the minutes from the September 19th public meeting of the commission. If there are no changes or corrections, I would entertain a motion for approval. Do I have the motion? Okay. Second. All in favor? Any opposed? No. Okay, thank you. Okay, commissioners, you've received the written updates from our centers. Do you have any questions on the written updates? Commissioner?
Yes, Mr. Chair, thank you. I do have a question for Ben and perhaps for Paul. On page 9, this is in the section of the update that relates to CON activity, and there's always a lot of back and forth with regard to the status of a lot of different CONs. There's one in particular that caught my eye, and that is listed on page 9, delicensure of bed capacity or a healthcare facility. It's a notice that a concern named NMS Healthcare of Hagerstown in Washington County, I guess, has requested temporary delicensure of all 206 CCF beds at the facility effective July 4th, 2017. So I looked this up, this facility, and it has a painful past. Actually, this summer, this is a nursing home that was closed by the federal government due to non-compliance with federal requirements, safety requirements, and it required relocating over 100 patients. So I guess my question is, with that kind of a sorry history, what is the status of these delicensed 206 beds in connection with commission activity?
So, Paul, do you want to answer that question?
Thank you.
We know that NMS is not directly involved, but what else can you say?
NMS was operating a facility under a lease with the owner of the real assets, which is Sabra, which is a real estate investment trust. It's a fairly common structure that you see in the nursing home industry. So the actual temporary delicensure was granted to Sabra because they own the real assets and they also own the bed rights. They had been leasing the facility to NMS. So the action was against NMS. They were the ones who were the bad operator and were forced to transfer the patient and stop operation of that facility. So Sabra, within their rights, once all the patients were transferred, temporarily delicensed the facility, and so they have the ability to come back within 12 months if they can find a new operator, and I'm quite sure that they are seeking to do that. But they have to bring a new operator in. They can't bring NMS back.
So the CON conveys to the landlord. Who was granted the CON?
Well, it isn't really a CON. You know, a CON. I think we should think of CONs as a regulatory approval from this commission to either establish a facility or alter an existing facility in some way. So there is no outstanding CON here. This is just a licensed healthcare facility, and it's temporarily delicensed now. The owner of the facility will have the right to find a new operator and to seek relicensure of the facility within a given period of time.
And would that come before this commission?
As staff, Sabra has to come back to us with their plan for reopening the facility, and then this agency actually would say, okay, you've met the requirements, you're legally bringing this facility back into operational status in the way that you have to. That's not something that typically we bring to the commission for a decision. It's simply something that's handled by staff. And then once we do that, then we would communicate that to the Department of Health, the Office of Healthcare Quality, who would then have the green light to consider a licensure application from the new operator. whoever that's going to
Okay, well, thank you. It just seems that we spend a lot of time in our CON reviews looking at the integrity of the operator, looking at the quality track record, looking at the financials, looking at the governance. And so this will be a transaction that, unless staff explicitly brings it to us, would result in a completely different operator at this facility than the one that started out, correct?
be. Definitely will be a different operator.
Right. So I would ask that when that relicensure proposal comes forward, that staff flag that for the commissioners to take a look at the new applicants.
Okay.
And to have a discussion with us about that.
All right.
Great. Thank you, Paul.
Thank you very much. Thank you very much, Paul. Ben, do you have an update? No.
Thank you, Mr. Chairman. Prior to the meeting today, the commission held a press conference to launch our new consumer price transparency website, where the cost, we had significant participation from the media. The Baltimore Sun, the Washington Post, the Baltimore Business Journal have all did stories on the release today. We had some additional inquiries from television media that we expect to be broadcast at some point today, and we expect the chair will give an interview with Maryland Public Television at some point over the next several days. Our broad strategy for raising awareness is we are launching by our standards, an ambitious social media campaign. We are active on Twitter and Facebook with updates. We have engaged our partners, consumer groups, and others to also blog and post regarding the site. And this is just the first step in a multi-stage process in which we are rolling out a new type of site that is focused principally on sharing information that consumers can understand and use. We started with 4 episodes of care: hip and knee replacement, hysterectomies, and vaginal childbirth for the privately insured population. It's important to note that the software, the episode, the bundling software that we're using has the potential to generate episodes of care for 90 different types of conditions. So we're proceeding prudently, I think, but we are going to proceed with expanding this rollout over the next several months and indeed over the next several years. Our next area of expansion is to include the Medicare population, as well as to expand the number of episodes to include some ambulatory surgical procedures as well, episodes as well. So stay tuned on that. We will keep the commission abreast of feedback we're getting as we move forward. It's also related somewhat. The commission, as all of you know, has been working with Leapfrog for several months on enabling Leapfrog to publish patient safety scores for Maryland hospitals. Up until this point, Leapfrog had been successful in publishing hospital patient safety scores for only 3 or 4 Maryland hospitals. The work that MHCC has done assisting Leapfrog in providing the hospital discharge data, hospitals submit to HSCRC, will enable Leapfrog to produce safety scores on most Maryland hospitals. That release will be on October 31st. The commission anticipates a press release approximately at the same time as the release of the Leapfrog results. And importantly, the commission will hear at its November meeting from Lee Binder, Executive Director of Leapfrog, on the results from this first reporting for the vast majority of Maryland hospitals. So I think it'll be an important meeting in November for the commission to consider the results and next steps in terms of our efforts to raise awareness, and most importantly, improve quality at Maryland Hospital. We really appreciate the work that the Hospital Association has done in encouraging hospitals to move forward on this initiative, and looking forward to partnering with them going ahead. But most importantly, to making sure that consumers have additional consistent information on facilities they may use here in the state.
Thank you very much, Mr. Director. I believe Eileen Fleck. Oh, Paul. Sure. Yes.
Leadership structure because it's the group that applies for cardiac surgery and PCI. Dr. Salinger is Director of Quality at the Cardiac Surgery Program at the University of Maryland. Howson. He also holds a clinical assistant professor of surgery at the University of Maryland Medical School. He's been a very active participant in the fight.
Thank you very much, Paul. Thank you very, very much. Are there any questions from any other members of the commission? Okay. Item 3. Ladies and gentlemen, we're going to consider an action on certificate of need. This is an exceptions hearing on the staff report and recommendation concerning Presbyterian Senior Living Services Incorporated, the Glen Meadows Retirement Community. The issue involves the consideration of exceptions filed by Glen Meadows Retirement Community to the staff report and the recommendation released on October 3rd, which recommends a denial of the Glen Meadows application. Glen Meadows sought a certificate of need approval to relocate 22 temporarily delicensed publicly available nursing home beds to the nursing home that it operates on its retirement community campus, and that is currently restricted to members of its retirement community. The restricted nursing home beds at the Glen Meadows Retirement Community that was established without certificate of need approval under the provisions of Maryland law that create the regulatory exception. The law permits a continuing care retirement community to establish and operate a nursing home for the exclusive use of contract holders in its continuing care retirement community. There are only limited exceptions. Glen Meadows seeks approval to convert the status of the 22 of its restricted beds through the relocation of beds that were previously operated at a Baltimore County nursing home that closed in 2016. Staff has recommended that the certificate of need application be denied. The staff report and the recommendation was issued on October 3rd, 2017. Glen Meadows filed exceptions to the staff report on October 16th, 2017. Glen Meadows requested and was granted an extension from the original due date of October 10th. Staff's written response to the exception was filed yesterday on October 18th. You were notified of the posting of the exceptions and the response to the exceptions on the Commissioner's webpage. In addition, copies of the staff report and the recommendations, including the Glen Meadows exceptions and the staff commission staff response to those exceptions, are included in the materials that were made available to you today. We will hold an exceptions hearing prior to the voting on whether or not to adopt the staff report and recommendation as the Commission's decision. Glen Meadows, through its attorney, Rose Matriciani, will have 15 minutes to present oral argument on its written exceptions, and Rose may and can reserve part of the time for rebuttal. The Commission staff, through Assistant Attorney General Sue Ellen Weidman, will have 10 minutes to present its argument. Deborah Donahue, who is Assistant Attorney General, is serving as the Commission's counsel today. And I want to make that clear. So we have a different counselor for the Commission. Following the rebuttal argument, if any, by Glen Meadows, the Commission will take action on the Certificate of Need application. During today's proceedings, Ms. Matriciani may introduce party representatives who are present and state their positions without the introductions counting against the permitted time for the argument. Ms. Matriciani, yes. Welcome to the Commission, and the floor is yours. You have 15 minutes.
I pronounce my name Matriciani.
Okay, all right, thank you.
I'd like to present the people who are with me today. Peter Davanino, Executive Director of Glen Meadows, Deborah Reitz, Nursing Home Director, Dr. Robert Dubell, President of the Residents Association, and Andrew Solberg, the Healthcare Consultant and ALS Healthcare Consultant Services.
Welcome.
I'd like to provide the Commission with a brief background for the project. Glen Meadows is situated in Glen Arm, Baltimore County, Maryland, and is a CCRC with 196 independent living, 40 assisted living, and 31 skilled nursing beds on its campus. Over the years, it has had financial challenges, and one of its biggest financial challenges has been keeping its nursing home beds occupied. Glen Meadows has no publicly available beds. In its conversations over the years with the Maryland Department of Aging, the Chief of Continuing Care suggested that the most viable way for Glen Meadows to meet its financial challenges at the least cost would be to try to purchase licensed beds without expanding the nursing home footprint at Glen Meadows. Therefore, when the opportunity arose to purchase licensed beds from Presbyterian Home, another CCRC in Baltimore County, Glen Meadows grabbed the opportunity and sent in its application to the Commission. An application which would allow to transfer delicensed public beds to Glen Meadows without increasing Glen Meadows nursing home beds or the inventory in Baltimore County. I'd like to begin addressing the exceptions by first addressing the bed need. Glen Meadows' application was submitted in February of 2017. The staff used projections for 2016 that were based upon 2009 data. Because this data was not up to date, we provided our own calculations based upon information supplied by the staff and projected a bed need which showed 523 additional beds were needed in Baltimore County. That constitutes a significant reduction in excess beds for Baltimore County. The bed need amount could be higher, but we were limited by old data. Even if the Commission accepts the 2016 numbers as valid, this project is not adding any new beds to Baltimore County's inventory, nor is it adding new beds to Glen Meadows. In addition, staff, while mentioning that Glen Meadows predicts it will actually use only 10 public beds on a regular basis, fail to recognize that the likelihood is that they will only use 10 beds on a regular basis due to their CCRC needs. For facility occupancy, although the staff acknowledged that the requirement of a 90% occupancy rate was not truly applicable to this project, they proceeded to find that Glen Meadows did not meet the standard, although not applicable. This is clearly erroneous. In Future Care Homewood, a case that was decided by the Commission in September of this year, Future Care did not meet the 90% occupancy requirement. However, the staff allowed Future Care to adjust its occupancy rate in order to meet the 90% requirement of occupancy for 2015 and 2016. In its rebuttal, the staff rationalizes its decision by noting that Future Care Homewood had previously experienced high occupancy, yet it did not meet the occupancy required for the standard at the time of the CON application. Even so, Future Care was found in compliance. I believe that this type of inconsistency by staff indicates a different treatment for CCRC. Glen Meadows does not have any public beds. It is not expanding its bed. While the staff allowed Future Care to manipulate its occupancy to meet the 90% standard under their discretion, there was no leeway given to Glen Meadows by staff when determining it did not meet a standard which they said did not apply. With regard to jurisdictional occupancy, although the staff acknowledged that the project does not result in a new nursing home, it continued an analysis noting that Baltimore County CCF beds were just under the 90% threshold, citing 2014 data and 2015 data of 89.4%. In 2015, their data was 89.9% occupancy on the average in Baltimore County. Therefore, even though staff acknowledged that this project did not result in establishing a new nursing home and thus the standard should not apply, they found Glen Meadows did not meet the standard because of a 0.1% to 0.6% occupancy rate spread. We believe that the standard should not apply and analysis should not have been done, nor the standard met by Glen Meadows because no new nursing home is being established and the percentage of occupancy in the county was basically 90%. While acknowledging that Glen Meadows provides quality care, staff focused upon the fact that Glen Meadows is a CCRC and should not be allowed to convert its CON excluded beds to publicly available status through the acquisition of delicensed beds because it is not consistent with regulatory policy established for CCRCs. This point made by staff only indicates their strong inclination to look at the purchase of delicensed beds differently for a CCRC than it does for a nursing home. The fact that CCRCs can have beds for its residents is not the issue. The issue is the purchase of delicensed beds by a facility that does not have beds for Baltimore County's inventory, is situated in an isolated section of Baltimore County where there are few or no nursing homes, and that is a facility that can offer quality care to nursing home residents. In its instructions to the CON application under this section, it states, if the current bed need projection published by the MHCC based on the need formula in the state health plan does not project the need for all of the beds proposed, the applicant should identify the need that will be addressed by the proposed project by quantifying the need for all facility and service capacity proposed for any development, relocation, or renovation of the project. Glen Meadows addressed this legitimate need for its financial viability and ability to continue to serve seniors, and if granted a CON, the ability to serve others in a quality facility in a distant far eastern section of Baltimore County. It has met this standard. Furthermore, in Ingleside at King Farm, a staff report and recommendation noted that the addition of public beds can improve the operating scale of smaller nursing homes, thereby lowering costs. Similarly, Glen Meadows would be able to improve its operating scale. Staff noted in its rebuttal that it did not recommend approval of the Ingleside project. The Ingleside project was a very different project, and Ingleside did not need publicly available beds to provide because it was already profitable. In Future Care, the staff recommended approval of the purchase of 30 delicensed CCF beds from MedStar, even though Baltimore City has an excess bed capacity. In that staff report and recommendation, the staff noted that Future Care did not seek to increase the total number of beds on the Commission's inventory for Baltimore City, but to relocate them. We have the same situation in the Glen Meadows project. In addition, staff considered that Future Care had a history of providing quality care. We have the same situation in the Glen Meadows project, where staff admitted that the facility provides quality care. Therefore, Glen Meadows should be found to have met the standard. Although staff concluded that the proposed project was not determined to be the most cost-effective alternative, they provided no basis for their conclusion except to state in their rebuttal that there were already too many beds in the county. This project involves no construction, no renovation costs, and the facility is already staffed for admission. In addition, there are no interested parties in the matter. The staff has determined that the likely impact on other facility admissions would be small. Glen Meadows should be found to have met the standard. Staff acknowledged that higher nursing home bed occupancy at Glen Meadows correlated with nursing home profitability. Even so, staff found it hard to believe that higher nursing home occupancy could be the salvation of the facility. This should not be difficult to believe since Glen Meadows proved that it needed publicly available beds for financial liability. Furthermore, they're mentioning community support in the procedural history. Staff ignored for purposes of viability, both in their report and in their rebuttal, the broad support this application had, including from the former chief of continuing care at the Maryland Department of Aging, the Glen Meadows Residents Association, and the Maryland Continuing Care Residents Association, the voice of Maryland CCRC residents in Annapolis. In addition, Glen Meadows would have had a letter from the Maryland Department of Aging, but staff requested that they not send a letter. In conclusion, I would like to say that Glen Meadows should be found to have met the standards for nursing homes and permitted to transfer 22 licensed beds from Presbyterian Homes to its campus because the CCF bed need projection was found by staff not to be applicable. The 90% jurisdictional occupancy was not applicable, but was essentially met. The project is not adding beds to Baltimore County's bed inventory. The commission has permitted the transfer of delicensed beds in a section of the state that already had excess beds and has accepted the creative manipulation of the 90% occupancy requirement. There is cost effectiveness in not adding beds and utilizing its current effective facilities, and Glen Meadows provides quality care and access in the northeastern section of Baltimore County where access to CCF beds is limited or non-existent. Additional revenue generated by the publicly available beds has been acknowledged and makes the project viable. The project has broad community support. Thank you for the opportunity to present. Did I say I reserved 3 minutes for rebuttal?
Oh, yes, yes.
Okay.
Councilor Weidman.
Rules are important. A certificate of need is required for Glen Meadows to add publicly available beds to its resident restricted nursing home. The nursing homes at CCRCs are different from publicly available nursing homes that are available to the general public. Glen Meadows has 31 nursing home beds that it got without going through the CON review process. And that's because the General Assembly decided that a CCRC should be able to have enough beds to serve its residents, whether or not there was need in the county overall, by which occupancy is determined and by needs and which need is determined. The General Assembly thought that the residents should have the availability to their own nursing home. So they put age in place within this continuing care retirement community. Need is required for a certificate of need. That a showing of need is necessary to obtain a certificate of need is not surprising at all. You know, as my mama would say, hence the name, certificate of need. Need is required. But it's not just any kind of need that must be shown. Glen Meadows had to show a public need for these beds. Under the rules in the nursing home chapter and the rules in the certificate of need procedural regulations, it had to show public need. Specifically, Glen Meadows had to show the unmet need of the population to be served. Now, the population to be served is those residents who live in Baltimore County who would go to a publicly available nursing home. Those are Baltimore County residents who are not members of a restricted community such as Glen Meadows. Glen Meadows' problem in this review is that there's no need for publicly available nursing home beds in Baltimore County. In fact, the Commission's projection of bed needs, which under Maryland law remains in effect until it is replaced, shows a surplus of 1,139 beds in Baltimore County. Now, Glen Meadows did its own updated analysis, projection of needs, and it came up with only 616 excess beds. But that's still a lot of beds. There's no need for publicly available beds in Baltimore County. Now, because under Commission regulations, Glen Meadows didn't show that its project will fill unmet needs for publicly available beds in the county, its application cannot be approved. Its true. Glen Meadows has a private need, but it has not and it cannot show a public need for the publicly available bed that it wants to add. It's important that there's not a hardship exception to the commission requirement that an applicant show that there's a public need to add publicly available nursing home beds. Now, Glen Meadows mentioned the Future Care Homewood case. That case is restricted to its facts. It was an existing, freestanding, publicly available nursing home that had high occupancy. Now, the occupancy, it is true, considered that there were a number of beds that had been closed for renovation at different times at that facility. But, that's reasonable, that's fair. If beds aren't available, you shouldn't hold it against the nursing home that they aren't filled. And the beds that were being renovated were not available. And the beds that were transferred to Homewood were beds from Good Samaritan Hospital that had also recently experienced high occupancy. Now, as far as Ingleside at Kings Farm, that really is on all fours. It was a CC, and it never came before the commission. There was never a commission decision. There was only a staff recommendation to deny, and the applicant withdrew its application in the face of that recommendation of denial. But it was another CCRC that wanted to add temporarily delicensed publicly available beds. Staff said there's no bed need for public beds in Montgomery County. It's recommended denial, and the application was withdrawn. In its exceptions, in essence, what Glen Meadows is saying to you is that you should grant it a CON despite the fact that it failed to demonstrate a public need for its proposed project. It says that the paper beds that it wants to add from a closed nursing home technically are in the commission's inventory, and that's true. It says that 22 beds aren't that many beds. And it says that it believes that the addition of these beds, publicly available, unneeded beds, would help Glen Meadows financially. Glen Meadows has a very strong emotional hook. That's true. But this is not a decision that should be made on emotion. This is a decision of whether or not Glen Meadows has met the legal requirements of showing need to obtain publicly available nursing home beds. The Glen Meadows asked the commission, in effect, to ignore the regulations that the commission adopted after receiving public input and going through the regulatory adoption process. Glen Meadows wants the commission to adopt a hardship exception during the course of this very certificate of need review. At this point, I do want to note that the commission only regulates the publicly available nursing home beds. There is nothing to keep Glen Meadows from adding additional independent living units or additional assisted living units that are highly occupied at their community. Rules are important. If the commission ignores its rules, especially something that's as basic and essential to what the commission does in certificate of need review as determining needs, and approves this application, then the next time the commission says, well, we can't do X because it violates the rules. Well, whoever's unhappy is going to say, well, gee, sometimes you ignore your rules. Well, don't let that happen. If you don't like the rules, change the rules. If you don't like the law, work to change the law. And in fact, the Court of Appeals, in a case involving a predecessor commission, which is Adventist Mid-Atlantic Healthcare, determined that or said specifically that the CON review process is not the time to change the rules. It wasn't the time to change the bed need projections, in that case that involved cardiac surgery. A change in regulatory process and policy and regulation should have three essential elements. First, it should result from a thoughtful and orderly process. Second, it should receive and consider public input. Third, it should take place outside of a CON review. Rules are important. Glen Meadows did not satisfy the rules, the requirements that the commission adopted in regulations that would justify the award of the certificate of need that it seeks. Staff requests that the commission adopt the staff report and recommendation as the decision of the commission and deny the application of Glen Meadows for a certificate of need. And that's because rules are important. Thank you. Yes.
I have a question before the council goes. I've had questions for both sides that I have not asked, and I'm not sure on our procedure whether there be a place for my to ask them. I wanted to make sure that was out before Ms. Wildman got off the podium.
Are these clarification questions?
But, well, yeah, there are questions about their argument and the facts on which it's based. All the other things.
Well, there's no taking of additional evidence at this time, so if there's
Yes, these are
clarification.
questions I want to ask the people making the arguments to me. I'm not trying to get evidence. I'm trying to get them to explain what their arguments are.
Okay, if it's clarification questions, that's fine, but if it's taking of additional evidence or testimony, it would not be.
Okay. So are we limited, should we be asking our questions as we go along? Or is there a separate time in our discussion when we ask questions so that people can make an argument?
I believe Ms. Mastrosini has reserved 3 minutes for rebuttal, so questions could come following rebuttal.
So, Ms. Wildman, or do I need to ask her now? Because she's going to leave and will not be arguing again, I understand it.
I don't get another chance.
Okay.
So,
Okay.
yeah.
So I should have been asking them all along, is what you're telling me. Is this like an oral argument in court where we should have been asking our questions as we go because there is no other opportunity outside of the oral argument?
Well, typically the argument time is limited, but if the commission has questions, this would be the time to do it now.
Okay.
But clarification only,
Clarification only.
right.
Those are the rules we have to operate under.
Sure, but I also think they should be able to explain the record, the facts in the record. It's my first question is, what is I've seen the argument about the 2009 plan.
Well, it was 2009, it wasn't a 2009 plan, it was 2009 data that formed the basis of the bed need projections, and which were updated, I think, effective through 2016.
Thanks, that was my question.
Okay. But if you, and I guess I'm going more, but if you look at the Adventist case, the Court of Appeals said it doesn't matter if the data is out of date. You need to go through a regulatory adoption process to change that. That out of date projections remain in effect. And in the nursing home chapter, as in the cardiac surgery chapter in about 1992, each has language that the projections remain in effect until replaced.
Thanks. So, but it's 2009 data is what we're talking about, not a plan with older data.
Right.
Okay.
The projections were last published, I believe, in 2016. Yes, 2016.
They've made an argument, Glen Meadows has made an argument on the based on a portion of the county they're in, having a need. Like, can you explain, are we forbidden from considering are we locked into having to consider needs county by county by county? Or should we be considering the merits of an argument that there is need in their portion of Baltimore County, even if it's not countywide?
The bed need projections are based on a countywide basis. The commission has never done sub-jurisdictional need for a service.
In the position of the staff, are we forbidden from doing that under the regulations, or have we not done that in the past, but not forbidden from doing that?
Well, the commission, okay. The commission has never done it in the past. I would say, I mean, as counsel for staff, I would say that it would not be appropriate. Whether it's forbidden, I would not say that it's forbidden. But if you know the Glen Arm area, and I go by it quite a lot, it's a rural, actually
No, wait a
beautiful
minute.
area.
I'm not allowed to elicit additional evidence.
Okay, you're right.
That's
Okay.
right.
But, okay.
So I really am asking the legal position. So I take it the position then is the regulations don't forbid us from considering sub-county, but it has not been the commission's practice in the past. And and it probably we don't have. Does the staff have a position on whether the record is developed enough? If the commission were to say, hey, we want to think about whether we should be looking at the need in that part of the county, do you feel that there is a record for that, or would further analysis be required?
Further analysis would be required, but if the published need projections that are in the Maryland Register go by county,
right,
and it shows that actually there's probably like more than 1,000 excess beds in Baltimore County.
Okay.
For clarification only, Commissioner Pollack.
Well, it's a clarification of the understanding of the law in this matter. So
Right.
They've purchased 22 beds, and
I assume it's a contingent contract, but yes.
a contingent purchase of 22 beds, with the understanding that that purchase obviates the need for a new certificate of need process.
No. The state health
Why
plan.
not just, so what, I guess my question is, why not just go through a new certificate of need? What does the purchase get you
Okay,
in this?
well, the thing
legally?
is, there's no bed need in Baltimore County. So you can't, because there's not a projection of bed need in Baltimore County, the commission's published schedule does not accept applications for new beds in Baltimore County, in
Got
any
that.
county, unless there's a projection of need, and there's no projection of
I
need.
got that. So what we're saying is it's not possible to purchase from existing inventory in the context of no projection of new need.
Okay, what the chapter, the nursing home chapter's rule provides is that in seeking to relocate temporarily delicensed beds, the applicant, and this is in 102408, I think it's 05B1, the applicant must demonstrate unmet needs of the target population, and that's required both in the nursing home chapter and in the procedural regulations to demonstrate unmet need of the population.
So in that sense, then what Glen Meadows is arguing, is that the requirement to demonstrate unmet need doesn't exist. They're disagreeing with that assessment by
well,
purchasing that.
in their application, they said that the project is needed to make Glen Meadows profitable. That's in their application at page 32.
Yeah, that's
They have said that there's a need in the northeast county corner of the county.
right.
Okay, they're required to show need. Surely they aren't saying that they aren't required to show need. They just haven't shown it.
So, if someone else were to buy the licensed bed, they want to buy, those folks also would need to come with a CON, and they would have the same needs going.
Yes.
I just don't understand why you would buy a delicensed bed if you have to show need anyway. Why wouldn't you just go through the process from scratch?
Well, it's not the process from scratch, but I mean, like I said, if you want to change the rules, change the regulations through an orderly process. But the rules require a certificate of need in this circumstance.
A new one. You can't
A
buy it.
certificate
You
of
can't buy
need.
it. You
These are beds
can't buy
from-
the old one. There had to be a certificate of need initially in order to get the bed. That had to have existed. And what you're saying is you can't buy it.
Well,
Yeah.
actually, I believe those beds predated the certificate of need law in Maryland. They're pre-existing beds at the now closed facility.
Okay.
But need has to be shown to relocate them. Yeah, in effect, what they're seeking to do is create another publicly available nursing home, because that one's closed. If this certificate of need is not granted, those beds go away because they've been delicensed for more than a year.
Okay.
Are there any other, again, clarification only? Commissioner Carr-Yard.
I apologize. Council, you speak about the rule. Is the rule that you're referring to in statute or in regulation?
The rules I'm referring to specifically are in the Commission's State Health Plan and the certificate of need procedural regulations. But of course, the certificate of need is defined in Maryland law, and that's at Health General 19-114C, as a certification of public need issued by the Commission for a Healthcare Project. So public need, by that definition, is required. Thank you.
Are there any further questions for clarification for the council? Thank you very much, Counselor. Ms. Matrosini, your rebuttal.
Thank you. Well, I like rules too, except I think they need to be applied consistently. And I don't see why Glen Meadows should be treated differently than Future Care. Future Care was transferring beds. They didn't meet the occupancy requirement, yet they were allowed to manipulate the numbers, and staff gave them discretion to do that. That's fine, but why can't we do it with Glen Meadows? Also, Baltimore City has a glut of extra nursing home beds. That didn't seem to matter in the Future Care case either. Glen Meadows, the staff is admitted, has quality care. There are 5-star nursing homes. Future Care provided quality care. Glen Meadows is situated well to provide quality care to outside residents and to those in the northeastern section. I can't rationalize the information regarding the northeastern section because the commission doesn't look at that and they don't print up the information. But we can say that they're one of few in that area and the only one for a number of areas. Thank you.
Thank you very much, Ms. Matrosini. Are there any clarification questions for Ms. Matrosini or for Ms. Weidman? Any?
Give me 1 second.
Okay. Commissioner O'Connor.
I just have one question. What is the total number of nursing home beds in this target region we're speaking of? Well, you've used the term target region.
In Baltimore County, there are a bit over 5,000 nursing home beds.
Okay.
That's in the entire county.
All right, thank you.
I have one for Ms. Matrosini.
Yes.
Sorry, I didn't mean to make you up. Assuming that we're only going to look at the county level and we were not going to look at the sub-county analyses, it wasn't clear to me from the analysis. Is there an analysis that you're putting forward that shows that there is an unmet need? Or is your analysis still like over, there's a couple hundred extra beds?
No, I don't think that was just our analysis. I think when we did the analysis on the formula for the beds, it was to show not only was it out of date, but it was only up through 2016, and taking the staff's data, not our data, it showed 500 and some fewer beds. I don't know if that number would, 500 and some more beds were needed. I'm not sure if we did the analysis if it would show even more.
Does that get you over the hurdle? You add 500 more beds are needed, but is it correct that that's still below, or that's still above what the need would be?
I think it is above, but I think that there was no consideration given to our argument, even though we showed there were no nursing homes in Baldwin, Glenarm, and other areas close by that could provide the care, and that we would be providing quality care. I think that was ignored. I think the support for the project was ignored.
Thank you.
Are there any further questions for clarification?
Just a second, I think I can refer you to the page in the staff report that shows that Glen Meadows did an analysis that showed that there were 600.
Excuse me. We have an objection, and I think the objection is sustained. I'm sorry, Counselor. I mean, I appreciate what you're trying to do, but the fact of the matter is that Ms. Matrosini did make an objection. I'm sorry. I'm sorry. We'll have to do that another time. I'm sorry. Are there any further questions for clarification? Not hearing none. The action here is this. I need a motion. I would like to hear a motion regarding the adoption of the staff report and the recommendation as the commission's decision. Do I have a motion? So moved. Do I have a second? O'Connor. Okay. Commissioner O'Connor. Any further discussion?
I guess it's a question for my fellow commissioners. It seems to me that the core of this is if we're only going to look at the county level data as our plan has, I don't see a good argument for need, right? Or are we going to introduce arguments that this portion of the county has special needs and it's not being met at a countywide level? And I think it's sort of a philosophical one. Some of our counties are quite large. And I guess I would be interested in knowing what other commissioners think about that before I vote, because I'm sort of of two minds.
Yes. Commissioner Pollack.
So I kind of I sympathize with that argument here, particularly in this particular situation. I live in Baltimore County. I work in Baltimore County. The need for nursing home beds in Dundalk and Essex is pretty irrelevant to what's happening in the Glen Arm area. And when you look at Baltimore County as a whole, I think it's very difficult to understand the needs of specific subpopulations. Unfortunately, we weren't given that data to consider today, but I think that's an important consideration here. And I think that I understand the challenges that this presents in terms of precedent, but the idea of allowing 22 beds, it seems very difficult to understand how that is going to impact the 5,000 bed market, and how it seems to me that could potentially have a very positive impact on the residents of that area who want to be able to stay in that area when they need nursing home facilities. And without knowing how many other beds are immediately around there, I can't make that decision very well. Yet I kind of know, based on my work with the Baltimore County Fire Department, there's not a whole lot else out there.
Commissioner.
Thank you. I appreciate your question, Commissioner Sargent, because it's a real conundrum in terms of local planning, any kind of public health planning. Looking at large jurisdictions tends to homogenize all kinds of data, and looking at the zip code level, looking at the sub-jurisdiction level is always much, much more revealing to look at variations in community, which are often dramatically different county to county. I would pick up what our counselor said in terms of the rules, and right now the rules are we do health planning based on jurisdiction. There are challenges, and I think it's worth taking a look at opportunities to do some sub-jurisdictional planning, and also cross-jurisdictional, because there's an awful lot of markets that cross between county borders. It becomes very, very complex, and I guess I would just say it is definitely it's complex in terms of community planning, but these are the rules that we have today, and this is the action that's before us.
Commissioner O'Grady.
I would like to ask that staff consider and look at the options, because I think, especially Baltimore County is certainly a big county. Some of these other where you have smaller population counties right next to very large. I'm thinking Frederick and Montgomery, Southern Frederick. There'd be lots of opportunities in Montgomery that they might not have if you only look at the Frederick kind of data. Some of those sorts of questions. Totally. This is sort of our issue today to work with what we have to work with. But I think that whole idea of thinking about, should it be 20-mile radius, should it be, you said zip codes, those different kind of considerations, just so that at the end of the day, we maybe have some policy recommendations to go back and think of a better way to do this that would be able to capture some of this more granular sort of dynamics that would be helpful to know in a situation like this. So I just ask if staff can come back to the commission with kind of a game plan for laying out some options And what does the literature say? What do these different things say for the best way to do this going into the future?
And that is a future consideration. That is not actually the matter before us right now. Right.
And I think it's sort of what you're saying, the subtext is that we should say, for today, we have always done this on the basis of the county, that's how the calculations have been done, that's what precedent is.
Okay. Any further discussion? All right, we have a motion, we have a second. All in favor of the motion to accept the staff report and recommendation as the commission's decision, all those say aye. Aye. Any opposed? Okay, the commission has adopted the staff report and the recommendation as its decision, which means that the Glen Meadows CON application is denied. I want to make one remark about this as after the fact. CON is one of the most difficult issues that we have to deal with, and we are going to have future considerations about reforming CON. And I think that some of the issues that come before us, there are many issues that come before us where we find ourselves in a kind of a difficult circumstance and conundrum, requires, I think, that when we do go forward in CON reform, that we keep all of these things in mind. This is part of an experience, and it's clear in my mind, anyway, that regulatory reform is long overdue. That's my views. Anyway, thank you very much, commissioners, for the ladies and gentlemen, Ms. Matricini, representatives of Glen Meadows. I'm sorry that things didn't work out for you today, but we do appreciate your being here, and we look forward to working with you in the future. Thank you very much. Okay. Next item has to do with Maryland's rural healthcare system, a regional approach to rural healthcare delivery. During the 2016 legislative session, Senate Bill 707, establishing freestanding medical facilities, passed into law. This legislation established a work group on rural healthcare delivery to oversee a study of healthcare delivery in the Middle Shore region and to develop a plan for meeting the healthcare needs of the 5 counties: Caroline, Dorchester, Kent, Queen Anne's, and Talbot. The final meeting of the work group was on Thursday, September 28th, 2017. Aaron Dorian, who is the Chief of Government and Public Affairs, and Dr. Joseph Ciatola, which one? Ciatola, okay. Not Chiatola, all right, co-chair. Well, that was the Rural Healthcare Delivery Work Group. We'll present the report and the recommendations. Thank Dr. Ciatola, it's a pleasure to meet you. Thank you very much for coming. Okay, the floor is yours.
Thank you, Commissioner Moffitt and commissioners. We are really happy to be here today. We worked really hard on this report for the last 14 months, and we think that we have something that the commission can really be proud of. Before I get started, I want to thank Kathy Rubin on our staff, who worked with me on this report and this project. It couldn't have been done without her. I'd also like to thank our research team, Dr. Luisa Franzini, Dr. Dushanka Kleiman from the University of Maryland School of Public Health, and Dr. Alana Knutson from the Walsh Center for Rural Health Analysis at NORC. They worked very closely with us during this process, and you have the report that they authored. Deborah Mazier, our co-chair, wishes she could be here today, but she's actually at a Health and Wellness Expo in Kent County presenting some of the findings in this report. So you all should know that the communities on the Eastern Shore were very involved in this. They're very interested in watching what we're doing. I'll be giving a little bit of background on the work group and the process, and then Dr. Ciatola is here to go through the recommendations. Just before we get started, I want to remind you all of some worrying trends in rural communities. These trends are occurring throughout the state, in our state's rural communities, and throughout the country. These are not unique to Maryland, but they are things that we have to think about. They include the declining use of hospital services and a healthcare workforce that may be under some stress, constraints in the transportation systems and limited access to public transportation. Further, declining hospital revenues and shrinking healthcare workforce limits the potential for innovation. The global budget system that we are under now is generally positive, but may pose additional challenges in rural communities where workforce capacity is limited. Just as a quick reminder, how we got here, SB 707 was passed, as the chair said, during the 2016 legislative session. There was a recognition at the beginning of the session that as we move into a new era of delivery, more services are being delivered in an ambulatory setting, services are being moved out of the hospital. Legislation was introduced to allow hospitals with declining inpatient services to convert to freestanding medical facilities. This legislation also changed the definition of freestanding medical facilities. In the time between the legislative session and now, MHCC formed a work group to look over our freestanding medical facility regulation and pass regulations on freestanding medical facilities to allow for a conversion. So aside from that, what did SB 707 do? Well, it set up the Rural Healthcare Delivery Work Group. It set the membership, which included General Assembly members, the Secretary of the Department of Health, CEO of rural hospitals, both on the lower Eastern Shore and on the Western Maryland, to gain a perspective from other rural communities, and included providers and consumers, local government officials, businesses, and labor leaders appointed by you all. The work group was established by MHCC in the summer of 2016. We appointed 2 local chairs, one from Chestertown, Maryland, that's Ms. Nazir, and Dr. Fiatola. The charge was to oversee a study of the rural healthcare needs in the five mid-shore area, hold public hearings, and identify policy options. And here we are now issuing the report. So what exactly was the study? The study examined challenges to the delivery of healthcare in the mid-shore area, including the limited availability of healthcare providers and services, special needs of vulnerable populations, transportation barriers, and the economic impact of closures. It was asked to identify opportunities created by telehealth and the Maryland All-Payer Model Contract. MHCC established an MOU with the University of Maryland School of Public Health and with the Walsh Center at the University of Chicago NORC. The study team underwent qualitative and quantitative analysis. They held focus groups in all 5 counties on the mid-shore, and they interviewed important stakeholders. Like I said in the beginning, this is a 14-month process. We've been doing a lot of work with this group. The whole work group met 7 times. The work group at its first meeting also established 4 advisory groups in areas including vulnerable populations, transportation, economic development, and workforce. Those groups met at least twice. The work group also held 5 public hearings, 1 in each of the jurisdictions on the Eastern Shore. And work group chairs and MHC staff met with legislative leadership multiple times. The research team conducted empirical research. They held stakeholder interviews. They convened focus groups. And the work group chairs, MHCC staff, and the research team met weekly or bi-weekly to move this process forward. Just a visual so you can see how all of this fits together. There's a lot of moving parts to this work group and study. The work group is in the middle. There was various inputs to the work group's recommendations. The work group did develop these recommendations from research conducted by the study team, from public hearings, and from the advisory group. We now are where you see the red arrow, which is MHCC. You all are here today to approve the release of this report. So with all that said, I'll turn it over to Dr. Fiatola to go over the recommendations.
That was a very quick synopsis of 14 months of extensive work with 34 members on a work group with all diverse interests and diverse personalities. But commissioners, on behalf of myself and my co-chair, Deborah Mazur, we would like to thank you for the opportunity to have been the chairs for this very important rural study. It has been a privilege and an honor to work with our partners in this 14-month endeavor, but we would also like to acknowledge the support, the guidance, and the outstanding staff of the Maryland Healthcare Commission, as well as the University of Maryland School of Public Health, as well as our consultants from the Wall Center and Newark. So thank you. If you turn to the next slide, the categorization and recommendations, and I will start this discussion off to say that both the University of Maryland School of Public Health, as well as the consultants from both Newark and the Wall Center, essentially mirrored the recommendations that you see coming out of the work group. The recommendations that came out of the work group were basically coming from the 4 advisory groups that we initiated. And what we did is we combined those 4 groups into 2 advisory groups so that there was a lot of cross data information, data sharing with these recommendations. I must be extremely direct about the finding that the communities feel that they need to have a voice in their healthcare systems, especially in rural communities, both the citizens, the stakeholders, and the providers of care. Care must be delivered to the areas that these patients need it. It has to be closer to home. And as you know, in rural areas, and when you specifically looked at the 5 jurisdictions of the Mid-Shore, that was an extensive geographical area with limited workforce, extremely limited transportation capability. And when you look at it, we have 2 of the counties that have no acute care hospital, Caroline and Queen Anne. Queen Anne has a freestanding emergency room, but no acute care hospital. The challenges in Dorchester, when you look at the health analysis that was done, both Caroline and Dorchester have some of the lowest, poorest health outcomes in the state. And I think these are the issues that really came to the forefront. The proximity to Delaware also added a conflict of where to access care, especially in the northern part and eastern part of Dorchester. They were closer to Delaware facilities, but yet if they had Maryland Medicaid, could they receive services? No, technically not. So a lot of these issues came up. We didn't have the advantage of essentially having an insurance individual on this work group because insurance became a question in many of the groups, the focus groups and the patient groups that were held in each jurisdiction. What we have come up with is a series of recommendations to essentially foster a new model for rural health. And I know some of you are probably old enough as me and to remember about 40 years ago, there was a new initiative in the University of Maryland called Shock Trauma, led by R. Adams Cowley. It was an innovation. It was extremely controversial, to say the least, in the beginning, but it led Maryland to be in the forefront of the delivery of trauma care. I think we're sitting at that precipice now, at the crossroads for rural health in Maryland as well as in this country. And the recommendations that we have put forth, specifically the first one, is to build a rural health collaborative, to have healthcare integrated, collaborative, to meet the needs of the region. And the old saying is, you've seen one rural county, you've seen one rural county. These have to be adaptable and flexible to meet the needs of the jurisdictions. The rural collaborative basically would pull the players in the jurisdiction together, starting with the organizational structure of what has been known now as an LHIC, the Local Health Improvement Coalition, that's been in many jurisdictions. We are fortunate in the Mid-Shore to have had the 5 jurisdictions in an LHIP, which was essentially composed of community workers, hospitals, EMS, social services, and health departments, looking at the needs, using that foundation to build on to a rural health collaborative, which could then launch a demonstration project called the Complex. It's what we envision as a one-stop shop. You not only have primary care, which could be through a physician, a nurse practitioner, or other extender in some of these far rural communities, but you also have social services, you have behavioral health capabilities, and you also have, with the use of both telemedicine and an improved electronic medical record system, so that there is a single common patient care report that is shared among the providers as well as the lab results and hospital stays, so that there is a coordination. We don't go chasing all over for evidence of the lab studies, test results, or what patient has seen whom. That is one of the key components of the recommendations, is to start this complex. So you want to ask a question while we're going? Because I think...
All right, you're doing so well in the presentation, I hate to interrupt. On the complex, are we talking about, is it a physical location, a purely virtual location,
it
a
can,
mixture?
what will determine the complex is the need. There's a basic complex, which is a primary care office. That could be in a school, it could be in a pharmacy, it could be in a fire station, it could be a mobile unit. Then the second phase, the next level up, would be more inclusive with specialty care, depending upon the needs of the location and how we can get care to the individuals. The third complex would be more inclusive with both oral health, social services, behavioral health, substance abuse, primary care, and specialists. Okay? But in order to do this, we need a workforce. And I'll guarantee you, looking at the Eastern Shore, and Jerry, don't take offense, it's getting old. Okay? We have an aging workforce in rural health. How do we improve it? How do we carry on the tradition of primary care, specialty care? Well, what we came up with is a recommendation. And back in 1972, 73, there were rotations of specialty services from the University of Maryland School of Medicine and the residency program, where residents went to specific jurisdictions and did maybe a month, maybe 6 weeks of a rotation at an outlying facility. So they got to learn what were the needs of rural services, what were the limitations. But what it also did was give them exposure and possibly a job opportunity when they finished their residency. That's how a lot of the orthopedic programs started in Salisbury and in Frederick and in Hagerstown, because I remember our residents going out for essentially rotations out there. There are limitations about this with graduate education, and I understand those, but these are some of the recommendations. The other thing is improvement of the LARP program through Maryland, so that there's better tax credit for those practitioners who are willing to allow a resident or a medical student to have exposure. And then the other piece that we talked about was grow your own. Take a local student who's interested in medicine or nursing, offer them a scholarship, but the guarantee you come back to practice in your community. And the same thing with medical school. Offer through the University of Maryland Medical School and Hopkins residency programs that are scholarship-based for those individuals from rural communities who guarantee to come back and work in their community. We need workforce. And the same thing for our nursing program, our paramedic program, our PA program, the local community colleges. And this can be done both from a regional input as well as state input and state support. Expanding community paramedicine and mobile integrated health. I don't know how many of you know about mobile integrated health that was started here 3 years ago in Queen Anne County with a pilot program through MIMS. We are 3 years into that program now. That program now has expanded to Charles County, PG County, Frederick County is getting ready to start, Montgomery County, and Salisbury Fire Department is now starting their program. Queen Anne has been doing it now for 3 years. And essentially I brought 3 years worth of data that I am going to give to the commission to share with the outcomes of what that program has done as far as reduction in unnecessary ED visits, unnecessary readmissions post-discharge, and with the component of telemedicine that we're now doing with a PharmD, we have significantly corrected the medication mistakes or discomfort that these patients have when they come home and they've got a medicine cabinet with 15 bottles of medicine. Which one do you take now? So the med reconciliation with the PharmD with telemedicine is very important, and linking them with their primary care. But what I really want you to look at in the study papers that I'm going to give you are the number of social referrals that has occurred because of this program, both housing needs, socioeconomic needs, behavioral health needs, substance use disorder treatment programs. These are already existing programs. The problem is we are not integrating. We also have come with a recommendation of an established program for a rural community access hospital. There is no question in our mind that is, as far as Chestertown is concerned, there is a need for a new designation because of distance. And when we looked at critical access hospital definition in the federal standards, and you looked at 35 miles, the problem with the Eastern Shore, it's not mileage, it's time of travel. You've got secondary roads, and depending upon the time of the year, God help you if you're on 50 or 301 trying to get to or come from Ocean City and the Bay Bridge. So we looked at travel time, and the realization is that we need inpatient beds in that facility. And we were recommending that both the Maryland Healthcare Commission and the Hospital Cost Review Commission consider a category of special rural community hospital needs. This is also applicable in Southern Maryland, Lower Eastern Shore, and Western Maryland. The recommendations that we have put forth from this study are not only applicable, but a great test site for the 5 jurisdictions in the Midshore that's applicable to the rest of the state of Maryland. And what my recommendation would really be is let's do the demonstration project in the Midshore as the model for the state of Maryland. We're getting ready to start total cost of care. We've got a 10-year window. Let's start this thing now, reassess it as it goes along. We need to be adaptable and scalable to what the needs are in rural medicine. And as that process, that complex is evaluated for both cost saving and quality care, then I think we can say to not only CMS and the federals, this is what an integrated collaborative network of care can do. That's pretty much.
So I guess I'm up to wrap this up after that very passionate presentation of our recommendations. Just so you all know for the next step, if you approve the release of the report today, it will be submitted to the governor and the General Assembly. We do expect legislation to be introduced in the 2018 legislature that could take up some of these recommendations in part or in whole. As always, budgetary issues will be a limiting factor, although we believe many of the recommendations can be established through projects that are already occurring in the state. For instance, the ICN could be a key technology platform which can undergird the complex. Coming up in the next couple of weeks and months is National Rural Health Day. Is actually November 16th. I looked it up and I had it incorrect on this slide, so I apologize for that. And the governor will be holding a press conference with some of his plans on how to improve rural health care on that day. And then there's also the release of the Maryland Rural Health Plan, which was written by the Maryland Rural Health Association. This plan has not been updated since 2007 and will be released within the next few months. So with that, we are here to answer any of your questions, and we hope that you approve the release of the report.
Any questions? Well, I want to thank both of you. I think this has been a terrific effort. I wanted to ask one question that has to do with the sense of unity on the work group. Is it fair to say that this report by the work group represents a very strong consensus among all of the members, including members of the state legislature? At our last meeting in September, the full work group unanimously, full consensus with very strong legislative support for these recommendations. Right. I looked at your recommendation, the HSCRC has capacities to establish a special payment system for rural hospitals that would apply to Chestertown, would it not?
Yes, it would. HSRC did discuss with us, with their representation, when we talked about the rural access hospital,
Right.
saying that in their current regulations, they do have enough, as they said, wiggle room to adjust.
Yeah.
But that depends upon what the determination of what is really needed
Right. Right.
from a service delivery line.
Well, I just want to say I've been following this, and I just myself, but I think that the access concerns are very genuine there on Eastern Shore, especially the travel, and also the fact that, as you know, you're getting a much older population of retirees where you're going to have a greater demand for medical services, and somebody in Chestertown can't afford to take the time to drive all the way to Easton, to get health care. I mean, we've got to make sure that we keep a lot of these things operating.
Well, and the other piece, when you look at that, if a patient is admitted from Upper Kent County to Easton for their care, how is their family going to get to see them if they're an elderly individual and they don't have access to a car? Because
Right.
there's really not good, and as we know, family is important for recovery.
Right. And access is one of the fundamental concerns of this commission. We have broad responsibility in that area, and so we want to promote that, I know. Other questions? Commissioner Thomas.
So, thank you for that report, and I had the opportunity to sit in on, by way of conference calls, some of your meetings. And so I want to attest to the degree of seriousness that everyone took this enterprise. So I think there's both a danger and an opportunity. The danger is to look at the results and the recommendations and then build something that doesn't meet them. One of the things that was really intriguing is that you talked about the referral process, housing. I mean, you went down a list of things that we typically don't associate with a medical hospital. And we call those the social determinants of health from a public health perspective. And so the opportunity is to make sure that if there is something that goes forward that is built or created new, that it reflects that new recognition that we must address the social determinants of health. And I like to make sure that in this report, there's some assurance that there is a recognition that when we say the word hospital in this context, we're not talking about my great-grandmother's hospital that only waited until I was sick. That there was a recognition that this new thing we want based on this kind of input will be something transformative and that incorporates the social determinants of health that you have so clearly documented in your report.
I think that without a doubt, this report, when you truly read through the full report as well as the report from the consultants, is a holistic approach to the individual care and wellness of an individual. It is not based upon bricks and mortar of structures. It is based upon the needs of the individuals in our rural communities. And with the complex that we have discussed, it is exactly that, a complex pilot, so that as you progress along, you make the adaptations and the modifications in order to address the needs of the specific individual jurisdictions where you are developing and delivering that care and coordination.
And just brief follow-up, as you spread out to other audiences, some who may not be as diligent in reading the entire report cover to cover, that there needs to be some key bullet items to make sure that when we use common words like hospital, that we're not talking about the old hospitals. You see what I'm saying? If the word holistic is important, then make sure that's in the language. That really, from where I'm sitting, needs to be lifted up, given all the work that was done and the tremendous input from the community and the legislature. It's an unprecedented process. So my big fear is that if we're not careful, we'll go forward and we'll just create what we know doesn't work. So lift those new things up as an example that this is not business as usual.
No, it is not. Thank you. Thank you, Commissioner Thomas. Yes, Commissioner Pollak.
So, outstanding report, wonderful work. You highlighted a couple things that I think are exceedingly important and near and dear to my heart. So one of them was the issue of the need for more practitioners in that area and the need to move some of our residents and medical students out into that type of community to as part of their training so that they're more likely to select a location like that to eventually practice. And as you know, that involves expanding additional residency slots, and it does in the primary care arena, in the surgical arenas across the board. And there's no mechanism for funding that in the state of Maryland today. That's gone now as a result of GBR and was never replaced. So in somewhere in the report, will there be a recommendation to consider the need to address the funding of growth of
Yes. It's in the full report.
And then the second thing is you talked about the community paramedicine program, and I want to congratulate you personally on your leadership in that area in the state of Maryland. We have a community paramedicine, mobile integrated health in Maryland because of your efforts on the shore. As you know, that area is that discipline is growing dramatically across the country in all sorts of different models, and those models include models where community paramedic programs are integrated into the fire service, sort of like yours is, and models where it's integrated more onto the hospital side of a ledger. You're allowing for both of those types of growth to occur because the finances are a lot different in the two different models. And there's I think, a big financial advantage under GBR to the health systems to incorporate this type of outreach to the population within the hospital system, as opposed to relying on the 911 system to do it. Are you incorporating both possibilities in this?
We are that's a component of MIMS, but we've recommended both expansion of it as well as sustainability of it, because right now the programs are running in conjunction with their regional hospitals or the hospitals in their jurisdiction, as well as the health department. And linking it with the health department is a key component of getting access to services that are already existing and can be collaborated with these individuals to meet their needs. Huge difference.
Commissioner O'Connor.
I applaud you and Deborah for an outstanding job pulling this all together. I didn't think you could do it, but you did it.
Well, thank you for the vote of confidence.
The one comment I have is, at the birth of this whole project, Senator Middleton talked about collaboration among the systems, namely, how is Anne Arundel and Salisbury going to integrate with this complex plan? Secondly, like you said in the summary, is there a possibility we can get graduate medical education money if we extend residencies out here? And thirdly, I think if you want to improve the workforce out here, Maryland right now is in the lower quartile of Medicare reimbursement. If you want to get doctors to come out to the Eastern Shore, there should be differential pay and reimbursement from Medicare.
These are issues that the legislature will have to address, but we've mentioned those in the report specifically because of the fact that there is such a shortage in workforce.
Any further questions? Oh, yes. Commissioner Carr-York.
Thank you, Mr. Chair. Hello, Dr. Ciotola. Nice to see you again. Thank you for the report. Very well done. But I want to go back to an issue that I raised when all of this started a year ago. And I understand that the focus arose out of the origins of SB 707 and who brought it to the forefront and who was concerned. But my concern is for the other half of the rural Maryland. And I saw there is one member from Garrett County, but I'm wondering how you are going to proceed to extend the study and or to address the needs of the very large area of rural Maryland that sits on the Western Shore and up into the mountains, which can be very isolating.
Well, we had the CEO from Garrett, as you know, on the work group. We also had the CEO from McCready in Somerset, as well as other members from an economic standpoint, that we're looking at the impact of the economic impact of what healthcare has for rural communities and small cities and towns. I think the way to really approach this as to how it will be dispersed to other rural jurisdictions, let's see how we can make this successful as a test pilot in the 5 jurisdictions of the Midshore. But there's also components of it that can be incorporated right now in rural communities. Doing a rural collaborative, bringing the people together so that you have input from the community as well as the practitioners. The mobile integrated health is already spreading throughout the state. The same thing looking at non-emergency transportation, specifically non-emergency MA transportation. There has been such disparity in the reimbursement rates for MA transportation. I think we need the Department of Health and the Medicaid individuals to sit down and look at how can we make this different? How can we get better non-emergency transportation for medical needs? So I think there's a lot of individual pieces sitting out there, and certainly the rural rotations could be used in other jurisdictions right now in conjunction with both the University of Maryland School of Medicine as well as Hopkins.
Absolutely. Thank you.
Commissioner?
Very quickly, thank you, Dr. Ciatola, for being a leader among local health officers, and particularly just to comment on the community paramedicine work that you've championed here and clearly has spread out across the state. The opportunity to leverage the resources that exist in communities from fire stations and paramedics and EMT, and to leverage that not just to the 911 crisis response, but to back it up and to get earlier into some secondary prevention, not only for chronic disease, but also for behavioral health. It's just a tremendous opportunity. In Anne Arundel County now, all the fire stations are open 24/7 for anyone coming in with no repercussions for immediate access into substance abuse treatment. And the paramedics are wonderful. We now have over 250 people. Some of them have come across the bridge, I have to say, but have come into to our fire stations. But the point is that the sustainability really needs to get into the financing in order to have perhaps paramedics and other non-traditional providers in non-traditional settings be able to be credentialed and to be able to bill for their services, which in fact is having, as I think your report will show, a tremendous impact in reduced readmissions and lower unnecessary ED utilization. So thank you for all that, and if there's ways that the local health officers can support you in the legislature, we'd be happy to do so.
Thank you.
Report.
Commissioner O'Grady.
Very nice report. Congratulations on doing it. The one thing that I would question as you try to move forward and move from recommendations into policy is, unless I've missed it, I'm not seeing anything that will give me an estimate of the cost of these different proposals. And my guess would be that some of them are quite reasonable and others are not, that they're going to be very expensive to do. And my experience in rural health is mostly at the federal level, but one of the difficulties is we are talking, by your numbers on chart whatever, 3% of the state's population. So you're going to have to convince the other 97%. So it probably would have been better to get the mountain folks in line maybe ahead of time, that they should spend money on something that is not in their constituents' direct best interest. So to a certain degree, I guess my recommendation, if you ever do this kind of thing before, the one thing I would say that I was looking for that I did not find here is that scorecard. Is that this proposal would cost 15 million over 10, et cetera. All I'm saying is now someone else will put those numbers to these proposals.
And Commissioner McGrady, you're looking at the MIC program I just gave you?
Yeah.
That is a totally grant-funded program that is coming both from the hospitals that participate, the county government, and then there is no charge for that service. That's the issue. There's no sustainability there without some mechanism to be able to sustain this, because what it is now is all grant-funded.
Right, which is not, as you say, is not a good long-run plan for public financing.
You live by the grant, we're going to die by the grant, and
right.
These programs are too important.
I'm just saying that without putting the numbers of what this,
I can give you the cost of what it starts.
No. I'm saying what you have here is a lot of different moving parts, and what you don't have here is what it's going to cost and who's going to pay for it. That's all I'm saying, that it's a great report, but it kind of takes us halfway down the road. And to have more legs, to have more credibility, right now it may be only your detractors who put the cost estimates on there, which is not to your best interest. So I'm just saying that if you ever have to do this again, you've kind of, in my way of looking and developing policy, you've told us half the story. You've identified the need, you've identified good ideas how to address that need, but you haven't told us how much it costs and who's going to pay for it. And like you say, grants are not a long-term funding plan.
There is the data there, we just didn't give it to you. I gave you the data to show you what the existing services were, because the cost savings are there. But the cost saving really is to the carrier. When you look at Medicare and when you look at the commercials, because one avoidance of readmission is a significant cost savings. One unnecessary ED visit is a significant cost savings. We have those, but I didn't want to burden you with financial issues because that wasn't our purview.
Okay. Commissioner Sargent,
Yeah,
chomping at the bit.
I don't know about chomping, but people have probably heard me talk enough today already. But I was looking at the insurance providers in the MISH program, and it seems to me like you really need a Medicare outreach as much or more than anyone else. There's 137 of the 160 events with primary insurance for Medicare, if I'm reading the last page.
That's the population that we're
Right.
dealing with
Right.
in rural communities.
Right.
You're looking at a Medicare age population.
What I want to do is avoid going down the rabbit hole just talking about commercial insurance, because that was, a small fraction.
Yeah, that's what I was saying. That's why we collected the insurance data to see, so that everyone can understand what you're dealing with, because this is a large Medicare population in rural communities.
Any further questions, observations? Doctor, thank you so much for the presentation.
Thank you.
Ladies and gentlemen of the commission, I need a motion to approve the release of this report to the Maryland General Assembly. Do I have a motion? Motion? Second? Okay, fine. All those in favor, say aye. Aye. Any opposed? Congratulations.
Thank you very
Aaron,
much.
stay there for 1 minute.
So,
Well, both stay there.
I think that most of the commissioners know this, but I wanted to make sure all did, and that is that Erin will be departing for a new position at the Maryland Hospital Association at the end of the month. Her capability and her enthusiasm are going to be sorely missed. Erin came in 2012 when my predecessor and good friend Dr. Cowdery said, I'm leaving you with quite a mess in the cardiac services chapter. They're going to have to figure that out. And I don't think that we could have navigated that effort in my first year without Erin's very strong support. And throughout the years that she's been here, I know we've gotten really an enormous amount of work from her. She'll be very sorely missed, but we certainly wish her all the best of luck at the MHA, and I'm sure we'll periodically run into her in various venues as our interest, both from the standpoint of professional, but also the very important charitable activities that Erin's taken a lead here at the Maryland Healthcare Commission. So thank you very much for your work at the commission, and best of luck.
Erin, do you have anything to say?
Well, I wish you would have told me you were doing this before, because I could have prepared
There.
some remarks.
No, this is a declamation.
Thank you all. I mean, it's been such a great experience working here with all of you, with all as the commissioners came and went. I've learned so much from everyone that's walked in the door, and we have a tremendous staff here at MHCC that I think that I will miss coming here every day. I will miss seeing you all every month, and I know that our paths will continue to cross. But thank you so much for the opportunity to work here, and I will miss all of you.
Thank you very much. Godspeed. Thank you. Thank you again, Doctor. Our next item has to do with health plan performance. The Maryland Healthcare Commission has been reporting on the quality of Maryland's health insurance plan since 1997. And over the past 20 years, we've modified the report to reflect advances in quality measurement and changes in the private insurance market, which have actually been quite dramatic over these years. We've modified the report in 2017, and Charlemagne, Chief of Provider and Health Plan Quality, will provide an overview of the 2017 Maryland Commercial Health Plan performance. Thank you so much. Sharma,
Thank you.
the floor is yours.
Thank you. Good afternoon, everyone. Good afternoon, Commissioners, Chairman Moffitt, and Executive Director Ben Steffen. Thank you all for having me today. I'm going to give a very brief update on the health plan performance results for 2017. To get us started, we'll just talk just briefly about what we're going to look at. Just going to state some objectives right off the top, then we'll take a look at what the health plan evaluation system looks like for any of our commissioners who are new or anybody in the audience who is as well. We're going to take a brief look at the demographics of the members covered under the plans that we audit annually. Our excellent performance areas we're going to touch on very quickly, our areas in need of improvement, our RELIC results, and I'll talk about what RELIC is coming up and any changes that actually, and the changes that we're going to be making to the evaluation system starting with the reporting year 2018. So I'm gonna try to describe the health plan performance evaluation system for you, discuss the evaluation results, and explain the streamlining process that we've engaged in over the past few months. So the health plan performance and evaluation system really is established to keep our purchasers and our consumers, of course, informed of the quality of the health plans, the commercial health plans that operate in the state. And that meet our reporting requirements, which we'll cover on the next slide. And also, of course, to provide some kind of a quality assessment of the performance of the health plan. In terms of what the components of that evaluation system are, they include Maryland-specific HEDIS and CAHPS measures that we collect annually, then plan-wide HEDIS and CAHPS audit as well, behavioral health assessment, which is a Maryland-specific instrument, the race, ethnicity, language interpreters, and cultural competency assessment, and plans also create a quality profile, which is a summary of the quality initiatives that they engage in on a yearly basis, and then the overall rating stars that are provided by plans. In terms of the participation requirements, per COMAR 10-2508, Section 1, participation in the health plan quality and performance evaluation system requires that a health plan holds a certificate of authority in the state of Maryland, that the premium volume exceeds $1 million, and that no more than 65% of the Maryland enrollees are covered through Medicaid. Plans meeting these requirements then become part of the evaluation on a yearly basis. The health plans, the table you're looking at is a list of the health plans included in the evaluation system for the 2017 reporting year. And in the column all the way to the right are the overall star ratings for the health plans. They range from 3.5 to 4.5 out of 5, possible 5 stars. And these are the health plans, both HMO and PPO plans operating that are included in our evaluation system. This next slide you're looking at is just a bit of demographics on the breakdown of our members that are covered by the plans included in the evaluation system. In total, there are just over 2 million members in the state that are covered under these plans. One-third of which come from Montgomery and Baltimore counties. And then by race, we had a large percentage of missing data on race. If you see the footnote at the bottom, we had about almost 47% of the race data missing. But for what we do have, the majority of the members fall into these three categories listed here. The majority of our members are also in the 40 to 59 age range. Now I'll take a look at the excellent performance areas. Under the excellent performance areas, plans are doing, across plans are doing well in four categories, namely the primary care and wellness for children and adolescents category, and these are clinical performance measures from the HEDIS, which is the Health Care Effectiveness Data and Information Set. Also respiratory conditions, adult and child, primary care for adults, cardiovascular conditions and diabetes, and behavioral health. There are areas in need of improvement here, and they do fall under the areas in need of improvement. These are specific measures on this slide. They do fall into the primary care and wellness for children and adolescents categories, as well as primary care for adults, general health category, and respiratory conditions category. The specific measures on which the plans are performing poorly are as follows: human papillomavirus vaccination rates for children and adolescents, biomass index, BMI screening for adults aged 18 to 17 years old, and bronchitis medication management for children. These are the areas in which the plans continue to struggle, and the star ratings are also lower across these measures for the plans. In terms of where the plans are doing well, we have a list here of the plans, and just comparing 2016 to 2017, these are the number of measures that met national top performance standards in 2016 and 2017. In 2016, we had 4 plans, a total of 4 plans, having measures meeting the national performance standards in the range of 16% to 44%. And this year we included 5 plans that have measures meeting the national top performance standards, and these are clinical measures again, with percentages ranging from 19 to 53%. In terms of the CAP scores, which are the Consumer Assessment and Health Providers and Systems Assessment, which is really a consumer satisfaction measure. The plans are, and I have side by side 2016 performance and 2017 performance, and the notable improvements are that all HMO global measures except the overall ratings for specialists have shown improvement between 2016 and 2017. And there's also been notable improvement on the PPO overall rating of healthcare only. And these are for the global measures. There are other measures included on the CAPS, several other composite measures with as well. But in terms of the overall measures, these are how the plans are doing. Yes. Should I go back, or this slide right here? The CAP. So these are percentages. No. I'm sorry, I didn't get your question.
CAPS gives scores in top box categories. So the percentage of patients who click one of the 2 top boxes, and
yes,
that's typically what that is.
Yeah,
that
so
doesn't tell you what your percentile ranking is relative to other similar entities around the country.
So this does, what this does is compare the plans on each of these measures to the national averages. And this, the overall, the global measures here are for good overall ratings, and good meaning that consumers selected an 8, 9, or 10 out of a range of.
That's a top box score.
Mm-hmm.
So those are, but the problem with just looking at top box scores without looking at percentiles is for example, an 83% HMO top box score could be in the 30th percentile nationally, because scores tend to be clumped in the upper areas.
Mm-hmm.
So just that's what I'm trying to assess.
Okay. So yeah,
what that information means.
Yeah. So really, what that information means is that the plans have an 83%, which is either, in this case, in your example, which is either above or below or at the national average. That's all it means for the national averages, comparing national averages only in terms of the ratings on these specific scores.
83 means, 83 with an arrow up means it's above the national
It's
average.
above the national average,
Okay.
yes. Mm-hmm. So anywhere you see an arrow going up, we are scoring on these measures above the national average. And the arrow down means we're scoring below the national average in these, for these plan types.
That's important for people to understand. So for example, the 84 with the bar sideways means that the national average is 84%.
Exactly. So we're scoring at the national average if the bar is sideways. If it's up, we're above. If it's down, we're below the national average. So for the RELIC scores, RELIC means race, ethnicity, language interpreters, and cultural competency. And it's really MHCC's efforts to really track health plan efforts to reduce health disparities. So the measures that you're seeing here, the plans report on a yearly basis. And this measure is a measure that has been, this survey, RELIC, this assessment is an assessment that has been tailored specifically for use in Maryland. There is, the measures are also comparable to national standards as well. So we do have national averages that we are comparing to. And this is what you're seeing in terms of the arrows. Once again, up arrow meaning above the national average. Our percentage is above the national average at or below the national average accordingly. So on the RELIC data, we're looking at how plans are getting, what kind of information plans are getting about RELIC information that plans are getting, meaning information on race and ethnicity, language interpretation needs, and cultural competency training and tailoring of programs for members. We're getting that type of information, and we're looking at how does Maryland, what percentage of the HMO and the PPO plans are achieving this, and whether the percentages are at, below, or above the national average. And we've done the same for all of the RELIC items. And these measures are important measures. Health disparities remains a priority for the commission, and I think in healthcare in general, just addressing them. And so we've looked at how plans are getting information. Is the information that they're getting accurate? Do they even have RELIC information collected and available for their own doctors and the staff? Are plans making use of the data that is being collected? And are members members with English, limited English proficiency being supported appropriately? Whether care is being delivered in a culturally competent way, and so on. In terms of improvement, in 2017 versus 2016, the plans have improved and are scoring above the national average when they were not in 2016 on making use of the data, which is very important. So we're checking to see if the plans are collecting the data, but also are they tailoring programs in a culturally competent way to address the needs of their members. So plans have shown some improvement on that measure. And also there has been some improvement on the HMO side regarding information available on provider directories, as well as member ability to search for physician information online, and health assessment programming as well. So the plans are continuing to improve as we speak to them. This is a priority for them. They are working hard towards these goals, and it remains a challenge, but there is definitely significant effort and movement on some of these measures. In terms of the reporting requirements and how we've been doing things, we have been collecting data, Maryland-specific data, which means that we have been requiring plans to submit CAPS, which is the consumer satisfaction measures. We have been requiring them to submit that information for their Maryland Book of Business, in addition to their plan-wide data that they would submit to NCQA, which is the National Council on Quality Association, National Council on Quality. Sorry? Quality Assurance, yes. And so we have been requiring these additional audits to be done. Moving forward, we will end the Maryland-specific CAPS reporting requirement, partly because we were not seeing much difference between the data that was being collected for the plan-wide, the entire Plans Book of Business versus the Maryland Book of Business only. So we've actually eliminated that requirement, and the change will be effective 2018 in the upcoming reporting cycle. The plans have welcomed this change. This impacts, kind of their resources that have been committed to the evaluation system. So that does help, and it also has resulted in cost savings on our end as well. We're just now only going to require of plans the data that is already submitted to the National Council on Quality Assurance, NCQA. So this is the accreditation body. It's a voluntary accreditation, but all of our plans are accredited with NCQA. So now we're just requiring what is already submitted to NCQA on an annual basis. That data will then be ascertained from NCQA, and we'll make it available for Maryland consumers on our website. We're also at this point suspending the collection of RELIC data, which is the Race, Ethnicity, Language, Interpreters, and Cultural Competency Assessment. We're taking a step back just to look and see whether we are collecting the right kind of data, whether we're collecting it the right way. Are there ways for us to do what we're doing a little bit better? Health disparities remains a priority, and so we want to make sure that we are pursuing this in the most efficient and effective way. Also, I should mention that NCQA is adding population health measures to the annual assessment. So we will be also getting population health data, and some of that data will also overlap with some of the data that we've collected through RELIC as well. So we are working with Johns Hopkins Bloomberg School of Public Health to get some interns who can assist us with the process as we review our approach to collecting health disparities data. And if any of our commissioners are interested, we would welcome your input in that process as well. Like I said before, our streamlining has resulted in nearly $1 million in savings. We would like to, of course, use some of the money that we have left over to improve the way we do things, and to, of course, promote our website and to improve consumer engagement, because that's why we have the data on the website, really to help inform consumers. So in conclusion, I'll just summarize kind of what we covered. So the Maryland Health Plans are maintaining a track record of good performance across many of the measures and indicators being evaluated. Overall, the health benefit plan continues to perform well when compared to the national average. The excellent performance areas continue to increase, which is a good thing, and our areas needing improvement continue to decline. And so we will continue our efforts to reduce health disparities, to measure plan efforts to reduce health disparities moving forward. And I will take any questions. This is what our interface looks like on the website. When consumers go, this is what they can see. They can click on the health plan guide. All the topics will drop down, and they can search through and find useful information. A lot of this information is presented in the form of star ratings, so it makes it very easy for consumers to understand and to make use of. And I'll take any questions.
Thank you, Ms. Charlemagne. This was a wonderful report, and once again, a terrific job. So we'll start with questions from Commissioner Thomas.
Again, excellent report, and a comment and a question. The comment is just to let you know that University of Maryland College Park is also a source of expertise for you to consider
Awesome.
as
Thank you.
the only school of public health at a state institution. And in other words, we work for
No,
you.
there's a limit on public advertising. You know that. I'm just saying.
Yeah.
Mention your website.
And poster charges.
Now for the question.
Yes.
Yes.
Why in the world is it so difficult to get race and ethnicity data? I mean,
I
what
have
is
asked
the
the
problem?
same question. I have asked the same question. This is what I've heard from plans.
Yeah, let me hear.
When we've, and you know, as we, in July 27th and 28th, we reviewed the relic results with the plans. We asked the same questions. How come it's so difficult? And they've said that a lot of their members refuse to provide the data.
So that members meaning hospitals refuse or patients refuse.
The members covered under the plans, subscribers, are not always comfortable with providing information. This is what we heard, and the plans have said that they've made efforts to educate members about how their race and ethnicity data is going to be used, that it will not be used
to hurt them.
Exactly.
So the mere fact that they think
Yes.
it would be used to hurt them should be a message to us. And I only mention this because there's so much differential response to things like quality based on these parameters.
Mm-hmm.
If you have zip code information, there may be a way to impute it.
Mm-hmm.
But I think that this is a serious issue because if we're not reaching everybody,
Mm-hmm.
or if these data are not reflective of the diversity of this state, it's a problem.
Yes.
And I don't accept all the excuses you get.
I know, but you know what? The plans do use a RAND cooperation. I think it's QDART. It's a method that they use to impute the race ethnicity, once again, based on zip code. And it uses census data, and it's a complex algorithm, but they do end up getting that data, but not all of it is directly from the plans. Another piece of data that is, according to the plans, is difficult to collect, or they don't ask in some cases, is educational level, a level of education, for example. So the plans have said that collecting health literacy data is more important to them than educational level, although in research circles, educational level is used as a proxy for socioeconomic status. So for me, collecting that data is important, but the plans have, some of the plans, and I can't say for all, but some of them have said health literacy data is more important to them than educational level, for example. So there are various reasons, and I've seen a lot of work done to try to encourage the plans and encourage members to submit that basic race and ethnicity data, and it seems to be an ongoing challenge.
Thank you.
You're welcome.
I don't want insurance companies trying too hard to get race and ethnicity data. CareFirst did not collect it until the state passed its law. As counsel to the company, I was very happy about that. There was no accusation that anyone in the company was making decisions based upon the race of who it was. Our job is to pay medically necessary claims. There isn't anything in our business that we use the race and ethnicity data or educational level data for. The health knowledge we could actually use in a wellness program. So I guess with a note of caution, I don't think we should uniformly assume that having insurance companies collect a lot of unnecessary information that we can't force people to answer is necessarily the best approach to this area.
So Commissioner Sargent, if I just may, because this is a very important conversation for us. I would agree with you if the data wasn't so clear that we have differential health outcomes, we have differential responses to patient experience based on, unfortunately, race and ethnicity. So I wish we were at a point of color blindness, but right now, that potentially, and the literature points this out, actually contributes to the continuation of the disparities that we see.
I guess the question for me, though, is you've got a problem with disparities in health outcomes. Absolutely right. What you've done then is gone to the commercial insurance market to impose a whole bunch of data collection ideas. We're not picking the doctors. We're not picking the treatment. And you really don't want that. So it's sort of like when we look at the CAP survey and you look at clinical outcomes measures, look at the things that they could be improved. I'm like, we will pay for those when people submit claims for them. But the insurance companies, our job is to pay the claim. I'm not sure that using the private commercial insurance system to do data collection is the right way to address disparity in health outcomes. They seem to be untied. So we don't address, there's Medicare, there's Medicaid, there's all the other outside of the commercial, that's not addressed. So again, I want to put a note of caution. It's definitely a worthy goal and things that should be addressed. But a lot of times the relic stuff can be overinterpreted because you're just looking at people who are paying for commercial insurance in the first place when you pull that together. And then that's not tied to outcomes. You don't need us to tell the doctors about the race and ethnicity of their own patients, presumably. How do we address the actual disparities? I don't think you address that through the commercial insurance. So I think that's all I'm trying to get at.
Commissioner O'Grady.
Yeah, everything you said was correct, but there's something else going on here, methodologically, I think, because you have terrible unreporting from the white population as well. So it's not that traditional problem we have that, why are you asking me about my race? Are you going to use it against me? Unless we think that the white population, the majority population, thinks their race is going to be used against them. And I doubt that. So there's something else going on here about these are really low response rates to a race ethnic, even, very informal or sort of awkward sort of, you look at school enrollment or anything else like that where it's totally voluntary. These are really low. So I'm thinking, given all your points, there's got to be another variable or two here that ends up with whatever it was. The white rate was 23%, and the black rate was half that, and then other was 8 or something like that. I would go back and methodologically look at this instrument and think about how we're collecting it. Is there something in that wording that is setting up red flags for everybody that they don't want to report their rate?
But I think historically, just your insurance company asked you for information it was going to use. So when you did the application, we asked about your health history, we asked about this. The implication is to put race on the application form is that race is relevant to something.
Although,
not to whether or not you ought to get insurance, though.
Right. But although today, you're asked your race on all kinds of stuff that you don't. Yeah, but it's just sort of, I want to register my car. They ask my race. It's sort of, I think we've reached this thing where race is being asked all the time. So the fact that we're seeing a kind of a 1968 response here, I got to believe there's something more to it than the general population. I don't want to tell Big Brother what group I'm in. So I just think there's something else going on here. And they're going to take a year and they're going to pull this all apart and put on a new carburetor and change the tires and figure out what they're doing. But I have to believe that there's something more going on here than the traditional reticence that we see in all kinds of other data collections.
And if there are no more questions?
Any more questions?
Thank you.
Ms. Charlemagne, thank you very much. What a terrific job.
Thank you.
Thank you
you.
very much. Okay. All right. Our next agenda item has to do with our favorite subject, the Certificate of Need program. Last June, the chairs of the Senate and House Health and Government Operations Committees requested that the Commission develop recommendations to reform health planning and the Certificate of Need process. Paul Parker, Director of the Center for Healthcare Facilities Planning and Development, is going to present the study plan for the Certificate of Need program reform, the modernization for the coming year, followed by an opportunity to discuss the plan and its elements. Paul, it's always a pleasure.
Thank you, Mr. Chairman, members of the Commission. To some extent, I think this is just kind of a follow-up to our recent retreat, where this was obviously a topic of discussion. So just to recap the the letter we got this summer from the General Assembly. I've converted the issues list from that letter into what I'm calling key questions that we want to try to answer in this study. How can CON regulation better reflect the dynamism and evolution of healthcare delivery? Can Maryland learn from other states about means for determining appropriate capacity? How should the law change in Maryland to improve the regulatory process for capital project review? How can the process of approving CON applications be streamlined? Again, looking to the law and regulation for more flexibility in how we process applications. How can the state health plan be amended? The state health plan, of course, are the regulations that govern certificate of need regulation. How can that plan be amended to create incentives to reduce unnecessary utilization, eliminate or consolidate regulations, determine service need in the context of Maryland's all-payer model for regulating hospital charges, and can we have a state health plan that is clear, unambiguous, and has appropriately applied criteria? How can duplication of hospital regulatory effort between the three agencies, the Maryland Healthcare Commission, the Health Services Cost Review Commission, and the Maryland Department of Health be eliminated or reduced? And then the letter also allows us to address other matters that aren't specifically mentioned in the letter as part of our study. So the timeline is an interim report by May of next year and a final report by December 1st of 2018. And some specific stakeholders that we need to involve in the study are outlined in the letter. And with apologies to all the physicians present in the room, I noticed this morning that we lost one of those stakeholders that was specifically listed. I think this happened during the editing of this slide deck. But physicians, yes, there's the guilty party right there. Physicians are prominently listed in the letter as stakeholders, and we unfortunately lost them off the list. But obviously you as commissioners, hospitals and health systems, physicians, post-acute care service providers, ambulatory surgery providers, behavioral health and substance abuse treatment providers, our local health departments and public health experts, employers, healthcare payers, and consumers. So in summary, the letter hopes that our study will propose legislative and regulatory recommendations that the state should undertake to adapt the CON process to today's healthcare environment. And the recommendations should be reasonable, actionable, and executable. So I wanted to give you a little perspective on kind of what's preceded this latest effort that's been requested in terms of evaluating CON, and then also some of the significant changes that have occurred in recent years in CON regulation. So back at the beginning of the current century, 2000 to 2001, that was the last time that the General Assembly mandated a comprehensive review of the CON program. And I think this was something that was done in conjunction with creation of this commission. This commission was formed by merging two commissions, one of which was primarily a commission for state health planning and CON regulation. And there were not significant changes in the scope of CRN regulation or the process that emerged from that comprehensive review. It was very comprehensive. It's a very thick document that examines all of the facility and service categories regulated under CON at that time. In 2005, we had a commission-directed review. So it was not comprehensive in scope. It was focused, I think, on a limited set of issues. There were some results that came about from that study. The capital expenditure threshold was raised from $1.5 million to $10 million for hospital projects, $5 million for all other categories of projects. And that's a threshold that's indexed for inflation. So now that has risen to $6 million and $12 million currently. And there were some process changes. The regulations basically imposed some meeting requirements that were intended to help speed up the process of getting to docketed applications, complete applications. I'd say we've had some limited success in that area. I think probably the biggest thing from my perspective is that we changed our regulations in ways that allow for greater use of what we call status conferences as part of the review process to seek project changes. We were pretty much operating with a system before that gave us kind of a binary choice. You know, you approve a project as it is, or you deny it. But now we do have an easier path to getting back to applicants and saying, we like a lot of your project, but there's some things that we'd like to change in order to bring it in line with the state health plan and give us a basis for approving it. In 2006 to 2017, over that period, we had a new category of healthcare facility created in Maryland, the freestanding medical facility, which are freestanding emergency centers. Those are created as pilot projects initially, and we studied how those pilots functioned in their initial years of operation. And beginning in 2015, those just became a regular category of healthcare facility that fell within the scope of CON regulation. And we've recently developed a new state health plan chapter for freestanding medical facilities. And then more recently, the freestanding medical facility model was adopted as a transition model for hospitals that want to transition out of inpatient care. And then the other significant change in Maryland in recent years in the Maryland CON program is there was a statutory overhaul of how we regulate cardiac surgery and percutaneous coronary intervention. That expanded the scope and formalized, the form of PCI regulation that actually was created by the Maryland Healthcare Commission, beginning in the late 90s and through the first decade of the 21st century. Informally, we created a process under which we allowed, based on scientific research, PCI to proliferate beyond hospitals that did cardiac surgery, which was actually the policy, the regulatory policy in place. And so we now have actually formally brought within the scope of CON PCI, rather than regulating it indirectly through cardiac surgery. And we've developed a state health plan chapter for these services that really opens up the regulatory process in ways that were not possible under the old plan. And the other thing I mentioned before we leave this slide is those two areas of change that I'm highlighting there, the freestanding medical facilities and cardiac surgery and PCI. In both cases, you see the use of a regulatory process that's not actually a full-blown certificate of need review. So in the case of hospitals that want to transition to freestanding medical facilities, we have what's called exemption from CON review. Should be a little bit easier and a little bit quicker, and does not include participation by interested parties. And that is also the regulatory process model for establishing a PCI program. Not a full-blown CON review, but we will periodically be doing exemption reviews where we allow hospitals to propose establishment of these types of cardiac interventional programs. And then the other thing we've done recently is we've tried to actually do some substantive reform of the CON regulatory process through state health plan development. And so I'm highlighting here, I think, the major areas in which we've been able to do that. The first two, general hospice services and home health services, these are services that we had existing state health plan policies that were extremely restrictive in terms of allowing new market entry. And especially in the case of General Hospice Services, the industry was very happy with that posture. And so we had a difficult time kind of working toward a reform. I don't think we've got a perfect plan now, but we were able to establish a plan in 2013 that is somewhat revolutionary, and that it really is all about the notion that we should try to increase, whenever possible, the use of hospice care in the state of Maryland. That's pretty unique when you look at the landscape of things that we regulate under CON. That's not the typical approach we take. So we're now targeting low-use jurisdictions, areas where we see low use of hospice as the areas where we want to have opportunities for new market entry of new providers. And the same in home health, very limited opportunities for a long time in Maryland for more competitive market development in this area. In 2016, we adopted a new plan that scraps the conventional need projection approach that we had been using, and which was the major limiting factor. And now we've opened up new market entry based on areas where we feel there's a lack of sufficient choices of providers, where we see highly concentrated markets, prevalence of poor performing agencies. And so we now have review cycles underway. We've finished one, and we have a couple more underway. So we are going to have more competitive home health markets on the Eastern Shore, in Southern Maryland, and in Western Maryland. Organ transplantation, we recently adopted a very radical, in some ways, new state health plan chapter, not so radical in others, but it does create new opportunities for new market entry. And we now have 3 new organ transplant programs proposed in Maryland, which you'll be enjoying reviewing next year. And non-specialized surgery services, what we call general surgical services, apart from organ transplantation and cardiac surgery. Here we are working on a state health plan. You adopted a proposed plan last month that will create more opportunities for development of more outpatient surgical facilities and somewhat larger outpatient surgical facilities. So there are a lot of things we can try to do through regulation, but I think we've all recognized through our discussions in the last couple of years that we really want to do a study like this to really look at how do we implement major reforms in the statute that will give us more ability to address some of the possible problems. This is not intended to be an exhaustive list. I wanted to kind of reflect the discussions that occurred at the retreat. I think this first one is maybe pretty specific to Maryland. We want to try to create, we need a more integrated approach to regulating hospital spending, which we regulate in a unique way in Maryland, that addresses both capital spending and making revenues available for operating expenses in a more integrated fashion than we're able to do right now in terms of the relationship between the Maryland Healthcare Commission and the Health Services Cost Review Commission. The next 3, I think, are more generic in nature, and they're pretty similar to what you see in a lot of states that have CON and periodically debate how to reform it. Fundamentally, CON regulation does restrict market entry and makes market entry more expensive. And so I think we definitely want to grapple in this study with the ways in which it limits competition and the potential for more competitive markets to enhance value, and the way that it may limit potential innovations in service delivery. The regulatory process is slow, it's burdensome. With apologies to all the lawyers in the room, it may be considered overly legalistic. And we also want to look at some of the benefits of regulating facility and service supply that we might want to preserve, but maybe CON isn't the best vehicle for preserving those. So I think that one of the things we want to look at, and this is not a new idea, and not necessarily something that's easy to implement, but are there ways we can use alternative forms of regulatory oversight to achieve some of the objectives that we address to some extent at least, in certificate of need regulation. So as discussed at the retreat, our two-stage study process, which to some extent is outlined in the request from the General Assembly. They do ask for an interim report and a final report. So in getting to the interim report in stage one, what we're proposing to do is, seek some fairly structured input from stakeholders. So we're not just going to put out a general solicitation for comments. We're going to ask them to address some fairly pointed issues that may be specific to their industry. We are probably going to solicit some support from consultants, and the two things I've listed here is an overview of the literature on the value and effectiveness of CON regulation, and possibly another area where we might want to contract for some work is possible lessons from other states, a review of what other states do in CON and how that might inform changes in Maryland. We're envisioning a small work group process with 5 or 6 commissioners and a limited number of stakeholders in this first stage, and convening a series of meetings planned around specific industry sectors and issues. So getting the comments from the stakeholders and then meeting with them to kind of further flesh out those concerns and their ideas. And the interim report in May, we see as a report that would define the problems and lay out objectives for reform. And then in the second stage, leading up to a final report, convening a larger work group, again, a certain number of commissioners, but a broader group of stakeholders, including possible subgroups. Series of meetings planned around developing consensus on the recommendations that we want to include in the final report and addressing specific problems. I've been involved in various roles in lots of studies of CON reform in a number of states. And so I certainly appreciate the difficulty of kind of really getting satisfying results out of these, but I think I'm cautiously optimistic that maybe we can come up with some pragmatic solutions that really will meet the hopes of the General Assembly in terms of being actionable, and get those into our final report by the end of next year. Okay, so that's all I had to say.
Well, don't run away. Are there any questions for Paul? Yes, Mike Grady.
Yes. So when we think about this and what we'll have as a final product, not to be hypocritical given what I said about the rural, will this be a thought piece, or will this actually be, I mean, we know that the people who come before us spend a lot of money and a lot of time obtaining a certificate of need. Will we have that kind of quantitative side that says, if you made this sort of a change to the system, not perfect, but the best estimates are? Or do we not have the budget for that kind of an effort? Because if I was in the Assembly or the Senate, I'd want to see, these are the 5 things you're going to do. This is what it's going to cost. Who's going to pay for them? This is what it'll save. These are the offsets. That kind of a real menu that tells me what my policy options are.
We do this?
So I think we have some flexibility to come up with some cost or savings. We'll have to think about. I mean, one thing we're looking at pretty much an open book right now in terms of what are the options to commit to. We can generate estimates on everything. I think we should be careful about that, but I think the goal would be to try to show offset positive or negative from any of the changes we have. Now, I want to defend the rural health group that there was interest in doing that, but given sort of the number of participants that were engaged in that debate, the work group was waived off coming up with hard estimates on some of those initiatives.
Okay.
So we will be operating under some of the same constraints. Important that we are also to get input from HSCRC and the Department of Health during the work group study and we've already reached out to the governor's office to at least make them aware of this requirement. This is not a legislatively mandated report. It is a letter from the committees, so somewhat below that, but it's something we're taking very seriously. But to your point, I think we'd like to do that to the extent we can, but given the scope of what we're talking about here, it's impossible for me to absolutely commit on every option.
Sure. Paul, have you ever seen it? Because you said you've looked at other states, you've been involved in other ways. Has anybody been able to put what you would consider reliable numbers on some of these changes and policy options?
I wouldn't say that I've seen great rigor in that area. I think any study of this kind is invariably going to involve predicting the consequences of these regulatory changes. How will this probably influence the things that people do in healthcare service delivery? Looking at those costs and those consequences is the more difficult part. Obviously, it's fairly simple to see how much money the state would save in terms of less regulatory activity by particular agencies. I think if we get into the area of how do we preserve maybe some of the regulatory oversight that we think is beneficial in CON, but do it through a different process that may involve different agencies, that's where I think we would really want to emphasize doing some good cost analysis to let people know that, because I think in many ways, just from a state budget perspective, that can be more expensive than what we're doing here. Might be cheaper for the providers in some ways, complying with that regulatory oversight, but it won't be cost-free. But that's where I think, when I think back at something we talked about a few years ago in terms of home health and removing that from the scope of CON, but then beefing up some of the regulatory oversight in the Department of Health, I think we had pretty unrealistic cost analysis in that. And
Well, at times, bad cost analysis is worse than no cost analysis.
Yeah.
So I guess just when you do, I would just ask that when you're doing your review of the literature, you're looking at what other states have done. If you find that, the guys in the state of Washington or Minnesota figured out a model that made sense in terms of that could be modified for our use, I'd like to pursue that and see if that's possible within a reasonable budget.
Thank you. Any further questions? Elizabeth? No? Nobody? Candace? Okay. Paul, thank you very much.
Thank you.
Thank you very much.
If we could just follow up on one point that I think the goal is to determine commissioner participation over the next couple weeks. I'll talk to the chair and the vice chair further on how we want to approach it and be back in touch.
Yeah.
I think the goal then would be, once the group is formed, to begin to work with that group to scale out questions. Doesn't mean that it means that there would be a group directly involved. I expect that all commissioners perhaps would be interested, but we want to have these questions out to the various sectors in November, because after November, the end of November, work sort of stops, and we really want the smaller work groups to begin meeting early in the winter so we can hit the deadlines that the two committees have put in place to have an interim report ready. And there will have to be the identification of problems given the template, the outline we've developed today.
Okay. All right. Thank you very much, Paul. Ben, you're on a roll, so why don't you tell us what's coming up for the next November meeting?
Yes, the November meeting will be November 16th.
Right.
And sorry to see that Dr. Pollack has left. We'll have a number of mandated report. One that is close to his heart is the status of the Physician Trauma Fund. This is an annual report. It provides a status on the expenditures in the previous year, as well as reserve levels in the fund. Dr. Pollack and I believe Commissioner O'Grady had asked us to come up with recommendations on on potential uses of the surplus. Post ACA insurance coverage has expanded. Consequently, demands on the fund have reduced. As importantly, the spend out between what are called standby costs, on-call costs, have continued to be pretty stable. They represent expenditures trauma hospitals encounter because they have trauma physicians and others needed in trauma care to be on call or standby. But the actual level of uncompensated care has dropped precipitously. So the level of spending has dropped, and the distribution of spending has also changed as well. You'll hear more about that. We have one mandate request. The Healthcare Commission does get requests in the legislature to evaluate proposed new mandates that have failed in the previous session of the legislature. It is discretionary on the part of the standing committee. A mandate that failed, that has no chance, likely will not be dropped, will not be asked to evaluate it. A mandate that the leadership senses has some potential will be asked to evaluate. And we have one, which is the coverage of fertility preservation procedures for infertility related to disease such as cancer, is one we're evaluating currently. We'll have our recommendations to you. We'll also have several proposed regulations on privacy and security, and an assessment of from our Health Information Technology Group on privacy and security breaches, as well as an announcement on the 6th round of telehealth grants at a meeting I was at on Wednesday at NCQA, which included participants from MedPAC. They mentioned that they were working on recommendations to expand coverage of telehealth for Medicare, and were very interested in our work here in Maryland on expanding use of telehealth. I particularly emphasize that I think we'll have some findings on providers and patients where it seems like take-up is successful, and others where a bit more effort is needed. Lastly, we will have a presentation, as I announced at the first part of this meeting, from Lee Binder from Leapfrog on their most recent release of hospital patient safety results for the entire country. This will be the first time that Leapfrog will be reporting for a sizable number of Maryland hospitals, perhaps nearly all of them. It's been through the work of Commissioner Moffitt and others that we've moved this initiative forward, and I expect that prior to that meeting, shortly after the official release from Leapfrog, that we would also have a press release from the commission itself. As usual, expect several several matters. And lastly, we didn't get this in our agenda this month, but we will have the commission retreat minutes for your consideration. We are now, as a result of open meeting requirements, going to have those before you. So I think it will be a varied meeting with a lot of interesting and important issues. Likely, we'll also have an update on the negotiations on the total cost of care demonstration agreement, which will be coming down the home stretch as the state tries to knock out the final elements in that before the end of the year deadline.
Yes.
I would just like to make a recommendation that, given the speed of the news cycle, that whatever press materials, press release you would like to do on the Leapfrog be done the same day as Leapfrog, not wait. I mean, we don't want to jump ahead of them.
Right.
Frog analogy. Yeah. Notwithstanding, but I think it should be simultaneous, given so that the coverage has our position as well.
And it's not uncommon that, press might, call individual commissioners and say, do we have a plan, either talking points, or we redirect all requests back to someone central.
So we need something. With the chair's indulgence, I would, we can talk further, but
Yeah.
typically, we would like to speak with one voice.
Yeah.
The chair, typically makes that call.
Right. And I think the basic rule is that whatever happens, we simply tell the truth. It has certain advantages. Do I have a motion to adjourn? All right. Motion, meeting's adjourned. Thank you very much, ladies and gentlemen. Thank you all.